Dr. Tyler Evans has battled Ebola in Africa, led New York City's COVID-19 medical response, and he warns that vaccine lies and policy failures are fueling preventable disease outbreaks across the United States. So, what will it take to rebuild trust in science and protect our most vulnerable communities? Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chairman of Yukon Health.
Dr. Tyler Evans is co-founder of Wellness and Equity Alliance, former chief medical officer of New York City, and author of Pandemics, Poverty, and Politics. Dr. Evans, welcome to CareTalk.
Thank you. Great to be here.
You've had a front row seat to some of the world's most pressing public health crises. I'm talking about Ebola, COVID-19. What drew you into this kind of work, and how has your global experience shaped your view of public policy here in the U.S.?
That's a great question. I was originally sort of intrigued or compelled to get into global health and to kind of focus on what we now describe as the social determinants of health, as the result of my spending a lot of time in Africa in the 90s and early 2000s, particularly during what was known at that time as the sort of the HIV crisis, particularly in southern Africa, and just saw way too many people, far too many people that were infected with the virus did not have access to the medications because it was outside of their hands, as they didn't have the purchasing power. There was a lot of sort of dissident science taking place. That was sort of, getting away from, how to both prevent and treat HIV, and then through decades of additional sort of experiences working in both the global South, which are low and middle income countries like Sub-Saharan Africa, Latin America, Middle East, as well as sort of the foxholes of the inequities in the United States in places like South Bronx, South Los Angeles. I really started to sort of understand the sort of the patterns here, and the sort of common thread through a lot of these areas or domains was the social and political drivers of healthcare, particularly access and sort of the outcomes of the sort of inequities in access. And as the result, I sort of formed this organization, Wellness Equity Alliance, in order to sort of bridge that gap, as we're sort of experiencing so many cracks in the pavement, which are worsened during infectious disease outbreaks, which ultimately then become epidemics to pandemics, many of which are preventable or more easily sort of mitigated if we actually focused on ways to manage and prevent and protect the most historically marginalized. But we don't. Unfortunately, and while we think sometimes we can learn from these lessons, we seem to be sort of taking several steps back.
So Dr. Evans, so that we know that we fail the most vulnerable, and it's just more exposed during a pandemic and an epidemic. What does the Wellness and Equity Alliance want to do to basically start to build bridges to better health for the most vulnerable? Because the things that fail in a dramatic way in a pandemic or an epidemic are there, to your point, in plain sight in places like where, you and I have worked in the South Bronx or the poor parts of Brooklyn or the poor parts of any urban or rural area. They're there right now. What does the Wellness and Equity Alliance recommend to sort of start to address those?
Sure. So Wellness Equity Alliance was formed, essentially to sort of bridge the gap. We were born out of the pandemic. We ended up working with government agencies across the country. We administered over 2 million COVID vaccines across the country, including over 1 million in California. What we were most proud of was really kind of working with the most historically marginalized. And the ways in which we were successful was working with community health workers, which we describe as sort of trusted messengers. We need to really rebuild that trust with the communities, and the way in which we're sort of traveling with RFK's posse and the information, that misinformation that's being sent out, it's even that much more challenging to basically get the right sort of messages out to the communities.
Well, how do you combat the crazy with content that's going to connect?
My mantra has always been stick to the science. As long as we can continue to stick to the science and work with community health workers, work with the communities to engage, medicine, scientists, physicians, nurses, frontline folks. There was a recent Pew study that identified physicians and nurses as being the top 5 most trusted professionals out there. And I don't think that has changed, that much. Scientists, it's a little bit different. But if we can continue to have those relationships, physicians and nurses, with the communities, with community health workers, community leaders who really have the faith and the trust of those communities, perhaps it's possible to just divert the crazy at the federal level. It's harder. It's much more challenging when you have people with so much agency, that people that were essentially on the fence about certain things, and you have secretaries and leaders of some of the largest health agencies telling you don't do this, don't do that. Of course, it's easy to sort of follow that direction. But if people really are able to connect with physicians and nurses and local public health professionals on a local level, it's possible to divert the crazy. That's what I've seen in a number of other countries as well.
And just for folks, I mean, the community health worker, that there's a connection that you're creating between the doctors and nurses. For those who don't know, maybe just quickly explain what and who a community health worker is, because they are creating a human bridge to that third of the population that is having real challenges. A third of the U.S., often in the poorest and most vulnerable communities, connecting to conventional healthcare. But just quickly describe who those community healthcare workers are.
Community health workers are they're really, this is the future of engagement in both healthcare and public health in the U.S., particularly with the most historically marginalized. Community health workers, this is nothing new. Community health workers have existed centuries, and it's in a more kind of formalized fashion. It's existed for decades with really good evidence in places all over the world. I've personally worked with CHWs in places like Democratic Republic of Congo and South Africa. And in the US, unfortunately, we've been sort of behind the curve in terms of incorporating CHWs into our workflow. Many CHWs there was not a reimbursement model for CHWs. So in US healthcare, if you cannot reimburse, it doesn't exist. Increasingly, that has started to change, and particularly in places like California, there are models in which CHWs are starting to become incorporated into the workforce. In terms of training for CHWs, there's a number of training programs out there. There's a number of certifications out there. Unfortunately, there's sort of too many certifications, and so it's hard to sort of really standardize.
But you're recruiting from the community for the community, and to create, sort of lightly trained folks who are typically non-clinicians, but really connecting the conventional infrastructure to the social anthropology, social topography, whether it's walking the streets of East New York or going door to door in a rural community that's having a hard time connecting. I think it's just awesome. So, David, it sounded like you hit a drum. Did you want to get in on this conversation?
I hit a drum. Yeah. I mean, so I tell you, you talked about sticking to the science. So let's do that for a minute. So one of the things that you've been pushing back on is the RFK Jr.'s false claims about, aborted fetus debris in the vaccine. So maybe you can just start with, what is actually in the MMR vaccine, and why did these narratives get out there? Why are they so hard to debunk?
So there's no, I mean, first of all, in terms of the fetus tissue and all that, whatever sort of claim that exists, it changes every week. None of that is based in reality, or there's no evidence for that whatsoever. The MMR vaccine is very safe. It's been used for decades. It's one of the most effective vaccines out there. There's typically adjuvants that are connected to any vaccine. It's just to kind of to boost the immunogenicity of it. Some of them are aluminum based, and they're typically very inert. Do not have any sort of issues. Vaccines do not give you the infection. So when people say, I got the flu shot and I got the flu, that is not a fact. That never exists. You can get a flu-like illness as the result of the flu shot. You can spike a fever. You can get some muscle pains as a result of the MMR vaccine, but you are not getting those infections. And so it's, again, really, really important to stick to the science. And, vaccines have been, both in the United States and globally, have essentially been one of the most important instruments that we've had in order to protect populations and to improve survival, improve morbidity and mortality. I've worked in, some of the poorest countries in the world, focusing on mass immunizations for children, which were challenging just to get in there. So the fact that we have them with such ease in the United States, and yet we have all these challenges with relatively good reason. I mean, parents have been scared as the result of the Wakefield study, which had an N of 4, which was essentially claiming that there was a link between the MMR vaccine and autism. That has been debunked. That paper was pulled. That scientist, Wakefield, has been discredited. Yet we continue to cite that, and now there's an investigation, an inquiry into the actual connection with sort of vaccines and environment and autism, even though that has all sort of been debunked. So we just need to stick to the science, understand the importance of the effectiveness of vaccines and the safety. That's been, again, we have millions of data points on these pieces, including COVID-19.
So on the MMR vaccine, I was just thinking one of the reasons maybe that people are open to these, concerns, safety concerns about vaccines is they don't remember, they hadn't seen what these childhood illnesses were like before. And I was just, MMR has its, measles, but also mumps and rubella, right? So I was just listening to Ron Howard's memoir, and he talks about being on the Andy Griffith show. And he says Andy Griffith said, he couldn't have kids, and it's apparently because he attributed it to he had mumps as a kid, and it left him, unable to have kids. And so I think, those stories were common. A lot of people with polio, in those days. How much of the vaccine hesitancy or just concern from parents, I'm not talking about from the secretary, is driven by just not seeing those things that it's meant to be protecting, and then you just worry about the vaccine itself? Is that a major factor?
I couldn't agree more. Here's the thing. We, as the result of decades of strong public health efforts, right, and getting to sort of outcomes of close to herd immunity for certain vaccine preventable diseases, we have no real reminders of what these diseases actually look like. So the fear factor, which is not the best way to communicate sort of messaging on public health, but a little bit of fear as a reminder of what sort of exists out there, it can be effective, and we don't have it, right? I mean, we starting to get it, right, with the measles outbreaks. Although for many folks it's an abstract concept. I mean, they're hearing it on the radio, but they don't actually know what it is. I mean, measles is one of the most infectious diseases out there, and gets people, particularly kids, very, very sick. I mean, while it can lead to death, in many sort of instances it doesn't lead to death, but it is very, very sort of a very sort of manifest disease that really causes a lot of sort of morbid sort of conditions, and if there are comorbidities, could really be worse. I saw mumps outbreaks taking place in Los Angeles. There was an outbreak that took place, I think, 2017, particularly among men who have sex with men. And so, we were seeing, different sort of manifestations of mumps, things that we haven't seen, for decades. And we saw sort of swelling of different sort of inflammatory glands, particularly the scrotum, and that was definitely sort of palpable. We have definitely seen certain sort of like episodic episodes of rubella, and then beyond that, I mean, we've seen we haven't seen polio, we haven't seen a lot of these other pieces because we are so protected.
So let's talk about COVID-19 for a minute. So COVID-19 was certainly a reminder of what could happen. And what I was, call me naive or over optimistic, which John never does, because usually I'm not. But, you had people that had the vaccine and COVID was prevented, or severity was reduced. And then you had a lot of people that, were dying, and they were saying, gee, I wish I hadn't listened, and, people should really listen to me and they should get the vaccine. And I was fooled by the propaganda, et cetera. So you'd think, based on our earlier logic, that, now people have seen it. And, you had people like repent from being vaccine skeptics, but somehow that hasn't translated. And if anything, just about the opposite. So how do we understand that?
I wrote my book, which is called Pandemics, Poverty, and Politics. The subtitle of that is Decoding the Social and Political Drivers of Pandemics from the Third Plague to COVID-19. And so, using COVID-19 really as a springboard to discuss many of the ideas that had sort of that had again emerged, in sort of my mind over the course of decades of my experience, but had sort of existed for centuries, was that there were social and political drivers that were impacting the emergence of epidemics that led to pandemics over the course, again, of centuries. And when we get to COVID-19, this was one of the pandemics that in contemporary society, almost everybody had exposure to, right? Everybody had exposure. Almost everybody was 1 degree of separation away from COVID-19. And which was very different from your HIV, your tuberculosis, your malaria, your pediatric diarrheal diseases, your meningitis, your meningitis belt. This is, for a lot of those diseases, some of the biggest infectious disease outbreaks that are currently sort of the most formidable sort of threats to our world in the global north, in the United States, Europe, many parts of East Asia. They did not have access to that sort of real manifest exposure. It wasn't real enough to them. For them, it was for many of them, it was an abstract sort of concerns. And while it might be charitable, while they want to provide opportunities to basically, help protect these other communities in sort of Africa and Latin America, et cetera, it wasn't real to them, with the exception of COVID-19. HIV was close, but COVID-19 really kind of, checked those sort of boxes. And so what we saw was, particularly, not only was everybody sort of exposed, but it was the most historically marginalized that were the most at risk. And so again, all these people exposed, but then they feels like, well, maybe I'm not the most at risk, because we knew that the folks that were the most at risk were those were, morbid obesity, diabetes, chronic comorbidities, and a lot of these were socially determined. So for people that had more privilege, that had more access, they felt, well, maybe we're not at risk as much as we thought. But what happened was, by not addressing the social and political drivers that impacted the most historically marginalized, we secondarily impact the sort of other communities, your closest communities, because hospitals were completely maximized, right? The hospital capacity was completely overstretched. ICU capacity was completely overstretched. And so as a result, for folks, suburban folks, urban folks, who, whatever we call it, 10%ers, et cetera, folks that had access, they no longer had access. So guess what? Now it impacts everybody, right? And if it doesn't impact them in a material way, it impacts their bottom line. The economics of not investing in good population prevention efforts are impacting these communities. So that's a really important message to get out.
Well, that's it for yet another episode of CareTalk. Our guest today has been Dr. Tyler Evans from the Wellness and Equity Alliance, and he is author of Pandemics, Poverty, and Politics. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chairman of the UConn Health System. If you liked what you heard or you didn't, we'd love you to subscribe on your favorite service. And thank you, Dr. Evans, for joining us this morning.
Thank you. Pleasure to be with you.